In this video, we'll review how to approach 12-lead interpretation. We'll review EKG basics as it pertains to sinus rhythm, review the 12-lead interpretation steps, look at how to label STEMIs, and finally we'll finish up with some STEMI mimics. To label a rhythm sinus, really you're doing an assessment of components. If the rhythm has P, Q, or ST for every beat, then that's a sinus rhythm. Let's look at what that means. The P wave is the atrial depolarization, also known as atrial contraction. The QRS complex is ventricular depolarization and atrial repolarization. You just can't see it because it's hidden under the ventricular depolarization. Finally, the T wave is ventricular repolarization. Again, if you have all of these components for every beat, that is a sinus rhythm. Let's review the numbers. I want to point out first, depending on the monitor brand, it's either going to show it in milliseconds or seconds. So quick conversion, 120 milliseconds is the same as 0.12 seconds. For our Zol-X series, we're using milliseconds, so the 120 versus the 0.12. All right, first the PR interval. We'll use this to look at, or assess rather, if there are AV blocks, atrioventricular blocks. The normal range is at 120 to 200 milliseconds. For the QRS duration, this we'll use to assess for bundle branch blocks, right or left, and the timing for this is less than 120 milliseconds. For QTC, I want you to think about it as it's dangerous or to use caution if it's greater than 500 milliseconds. And what I mean by danger is you're going to be careful about giving certain medications, and we'll review more of this later. For the EKG paper itself, I want to review a little bit of the timing. So for the horizontal boxes, going left to right, one small box is 0.04 seconds. One large box is 0.2 seconds, and 5 big boxes is 1 second. So this paper here is 1 second, or 1 second strip. For the vertical boxes, up and down, this is not about time rather than it is distance. So we refer to it as millimeters. So one small box is 1 millimeter, and of course 5 small boxes or 1 big box is 5 millimeters. We've captured this 12 lead and now we need to interpret it. I often see people get stuck into the way of evaluating ST elevation immediately after obtaining a 12 lead. Doing this can easily get you into a position in which you commonly or frequently mislabel 12 leads. 12 lead interpretation is about having a systematic approach. I'm going to provide you with the 12 lead approach that gives you specific steps to follow to help you increase your success with 12 lead interpretation. For the 12 lead interpretation steps, we'll talk about it and then I'll do an example 12 lead interpretation. Number one, first thing you need to do is look at AVR. AVR should be pointing down, also termed a negative deflection. If you have a positive AVR, likely what's happened is you switched the limb leads, like right or left arm, right or left leg. So positive AVR, make sure your leads are on correctly. There is a small group, about 3% of white Caucasian males, that will have a normally positive deflected AVR. Next, we're going to go to V1 and we're going to do rhythm evaluation. What we're talking about here is, do we have all of the components? P, QRS, T. Is there a P for every QRS complex followed by a T? Is it sinus or not? That's what we're looking to say. Is this a sinus rhythm or not a sinus rhythm? 3, we go to the numbers. On every 12 lead, it prints out, either depending on the model, before or after the 12 lead, it'll give you PR interval, QRS duration, and QTC duration. We're going to evaluate those numbers from what we talked about previously and determine whether we have any issues. Next, axis deviation. There are many methods to do this. The one that I like is to evaluate leads 1, 2, and 3. If all 3 leads are pointed up, positive deflected, then that is normal. If lead 1 and lead 2 are positive and lead 3 is negative, then that is physiologic left axis. If lead 1 is positive, but lead 2 and lead 3 are negative, that is pathologic left axis deviation. Anytime that lead 1 is a negative deflection, that is a right axis deviation. This can also cue in that you have the limb leads reversed. This will also usually represent when it's false with a negatively defect or a positive deflected AVR. Last thing we do is ST elevation. There are many ways to interpret this. We're going to review the I see all leads method. So for inferior, I inferior, that's 2, 3 in AVF. For septal, or S, IC, that's leads 1, 2. And for interior, A, it's V3, V4, and then L, lateral, V5, V6, 1 AVL. I want to go into a little bit more detail about the ICL leads. The phrase ICL leads is a memory tool. The first letter of each word tells you the location of the MI. So for I, inferior, the word C, the first letter is S, that's septal. For A, for all, the first letter is A, anterior, and the last word, leads, the first letter is L for lateral. So it's simply a memory tool for when you're evaluating a 12 lead to help guide you to be able to label it correctly. This chart here shows you where each lead goes for the color and then of course the label all. So 2, 3 AVF, inferior, that's the I. Next you go to the septal evaluation, V1, V2, then all, interior, V3, V4, then finally leads, 5, V5, V6, 1 and AVL. That is the method in which I recommend that we evaluate 12 leads. The ICL leads is simply a memory tool to help guide you when you're evaluating. Now I'll do an example 12 lead interpretation. Step 1, AVR evaluation. AVR is negatively deflected, so now I know I can interpret this 12 lead. If it were positive, I would stop and check my limb leads. Next, go to V1. This 12 lead is a great example. V1 tracing, the amplitude of the P and the T weight are very small, so it's hard to see them. So what you can do is you can go down to the next V lead, and in this case V2 is very clear, or V3, either way. So we'll use V3. V3, it's got a clear P wave, then a clear T wave with a clear QRS. So I see P, QRS, followed by a T wave. Next beat, P, QRS, T wave. 2 in a row. The distance between the P and the Q responser are not changing, so it's constant. So I can call this a sinus rhythm. Step 3, I would go to the numbers. I would check my PR interval, my QRS to make sure that I don't have any numbers that are outside normal range, and then would take further evaluation. In this case, these are all within normal limits. So now that I know that I have sinus rhythm, next thing I do is I'm going to do axis evaluation. So I'll look at leads 1, leads 2, and leads 3. Lead 1 and lead 2 are clearly positive. Lead 3 is what's termed isometric, meaning it's tall or it's positive as it is negative. This can be used kind of either way. So I would call this normal axis deviation. Next thing I do is we're going to do a ST segment evaluation. So I'm going to use my all ICL leads mnemonic. 2, 3 AVF. ST elevation, nope. 2, 3 AVF, there is no ST elevation or depression. So IC, as a septal, V1 and V2 septal leads. There is no ST elevation or depression in V1 or V2. IC all, 3 is, all is interior, V3, V4. V3, V4 does not have any ST elevation or depression. Lastly, leads, IC all leads. L is lateral, V5, V6, 1 and AVL. There is no ST elevation or depression in V5, V6, 1, and AVL. Last little section I would do is look at the rate. So in this case, I already know this is within the 60 to 100 for the normal rate range. So this is a normal sinus rhythm 12 lead. Next, we'll go over 5 different STEMI mimics, common ones. So if you do your normal evaluation, you'll see that there is some ST segment elevation. Most notably 2, 3 AVF, V2, potentially in V1, V3, and V4. So what I want to show you here and why this is a mimic, it looks just like a STEMI. What this actually is called benign early repolarization. This is a normal finding. This could be in a young man who does not have classic chest pain symptoms. So the memory tool here is, if you look at it, it will create a little smiley face, the round rising. In a STEMI, typically what happens is you create a box. So it comes up, goes straight over, and then it comes down to create the end of the T wave versus this rising. This is more classically of the BER versus ST elevation in an MI. If we go back here, we can see pretty clearly, if you look at V2 and V3, that it has that upward slope versus the box. Number 2, we're doing our normal evaluation, and we get to AVR, probably negative, hard to say. Check our leads, they're on right. Next, we move over to V1 to do our evaluation, and we notice that the QRS is pretty wide. Go to our numbers, and sure enough, it's greater than 120. That means that we have a bundle branch block. In this case, because V1 is pointed down, a negative deflection, that is a left bundle branch block, and that's what this is. Because it's a left bundle branch block, you can't classically evaluate ST elevation if it wasn't a bundle branch block. So you say, oh, look at V2 and V3, there's this ST elevation, this is an MI. That unfortunately is not the case. There is a criteria called Sgarbossa. Sgarbossa criteria. This was originally created in the late 90s by Dr. Sgarbossa, and then it's been since modified to make it more specific, meaning that if you have a positive finding, it's more accurate. So we're using this modified criteria. I'm going to go through the criteria, and then I'll show you on leads to help with the understanding. Criteria A, concordant ST elevation equal to or greater than 1 millimeter in 1 lead or more. Concordant means that it goes in the same direction as the complex. So if you have a positively deflected complex, the ST elevation would go up towards the point. Criteria B, concordant ST depression. So concordant, same way as the complex. Concordant ST depression equal to or greater than 1 millimeter in 1 or more leads of V1, V2, or V3. V1 through V3 are normally negatively deflected, meaning going down. So you're having ST depression in V1, V2, or V3 greater than 1 millimeter in 1 or more leads. Criteria C, proportionally excessive discordant, so going the opposite way of the complex, of ST elevation in 1 or more lead anywhere with 1 or more millimeters of ST elevation as defined by 25% of the depth of the preceding S wave. This sounds confusing and it's a mouthful, but I'll show you here in a second what we're talking about. So this photo, a little orientation. From left to right is A, then it's criteria C, then criteria B. I didn't make the photo, I just labeled it. Criteria A, that's the 1 millimeter of concordant, so same way as the complex, in 1 or more lead anywhere. So looking at this, the QRS is positively deflective, meaning that it's pointing up, and the ST elevation, where you see the red arrows, is pointing that it goes towards the direction of the complex. That is positive criteria. Next, the B criteria is 1 or more millimeters of elevation in 1 or more leads of V1, V2, or V3 of ST depression. Since V1, V2, and V3 are negatively defective normally, it's evaluating depression. So in the photo here in B, you see that the complex is pointing down or negative deflection, and the ST depression goes in the direction of the complex. This also meets criteria. Lastly, for criteria C. So look at the complex here to look at it. So obviously it goes Q down, or Q up, then down to the R wave, and then up to the S. So that long one where the photo is showing the greater than 5 millimeters, that is looking at the S wave. That long one on the right-hand side is the S wave. And you can see there that this 5 millimeters is greater than 25% of the total S wave. So that's positive criteria. Again, it said it's discordant, so going the opposite direction of the complex. This case in C, the complex is pointing negative down, and then it's ST elevation in the opposite way of the complex. This also meets criteria. For this third semi-mimic, let's evaluate the 12 lead. So you'll see here there's a lot of ST segment problems going on here. So let's evaluate. ICL leads, 2, 3, AVF. Definitely elevation in lead 2 and AVF, okay. Next, V1, V2. There's some borderline ST depression in V1. Definitely elevation in V2. Next is V3, V4. Definitely elevation in V3, V4. And then lateral leads V5, V6, 1, and AVL. Definitely elevation in V5 and V6, 1, and AVL. So when you have this global ST elevation, this is not an MI. What this is, likely it's pericarditis. For the fourth semi-mimic, this 12 lead right here jumps out at you. The QRS complex is wide. There's ST elevation. Before we get crazier, I want to look at this. At the very bottom, you see the arrows. Those are pointing to the pacer spikes. On the top right of the writing of the written stuff, you'll see it says electronic ventricular pacemaker. Make sure you don't have a paced rhythm. On our ZOLL X series, sometimes in the 12 lead, you won't see the pacemaker spikes, but you will see it when you're not in 12 lead mode. So don't get confused and call it a STEMI when it's really not. For the fifth and final semi-mimic, we can see here that this is a challenging 12 lead to interpret. Looking at leads 1 through 3, it's AVR, it's kind of difficult to say what's going on here. What is the key to this is you see the really tall peaked T waves in V2, V3, V4, and V5. That's the key here. Peak T waves are hyperkalemia or high potassium. You see there's ST elevation as well. That can't be interpreted in this scenario with a high potassium. Some final thoughts. Always treat your patient, not your monitor. If you have a patient that does not have, ST classic findings for a STEMI, but they have all the normal chest pain symptoms, treat that patient, not the monitor. Next, in a right bundle branch block, you can treat the ST elevation normally, meaning if they didn't have a right bundle branch block, use that criteria to guide you for ST elevation. The key to 12 lead interpretation is a systematic approach. Do it the same way every time, and that will prevent you from making mistakes. Lastly, for the quiz, it's going to be a little bit different. We'll have 5 EKGs for you to interpret. I want you to provide a written interpretation using the approach lined out in this training. Provide as much detail as you can to ensure that you can get all the full points. The example is, right out there, AVR is negative. That way I know that you're evaluating AVR. In the next video, we'll do an in-depth explanation of axis deviation and why it matters to evaluate it. And we'll do a QTC evaluation purpose and why you should be monitoring that. Quiz expectations. With the request to provide lots of detail, this is the required information. Provide the rate, the rhythm, I'm asking if it's sinus or not, the estimated numbers using the box counting method, provide the PR interval and the QRS duration, provide an access labeling, and ST elevation. If you have any questions, you can always call me at any time. This concludes the 12 lead interpretation approach.